I would like to welcome you all once again at our webinar entitled Europe's Beating Cancer Plan. And I would like to give the floor to Mr. Jacek Safuta, the Director of the European Parliament Information Office in Poland. The floor is yours. Good morning, ladies and gentlemen. I would like to welcome you at our debate. As you know, healthcare and health protection, it is not an exclusive competence of the European Union. It is also not the shared competences. It is this complementary competences. Therefore, the European Union can support actions by the member states. However, member states are, first of all, responsible for health protection. We have public opinion poll that show that citizens of the European Union, including Poland, list public health in the first place of any political priorities where the European Union should take action. Today we talk first of all about the coronavirus situation, and when the attention focuses on the pandemics, European institutions notice that many member states neglect other diseases such as cancer. Consequently, the European Parliament tries to answer citizens' expectations, and we have created a special committee for cancer, and we also impose on member states to dedicate 5 billion euros to dedicate to the European Union program for health. It is another edition of the European Union for health within the multi-annual budget for the next 7 years, the budget of the European Union. It is not the only program dedicated money to health protection, but it is the flagship European Union project. However, European Parliament's actions will be best described by Mr. BARTOSZ ARŁUKOWICZ, who is the head of the Special Committee on Beating Cancer in the European Parliament. I would like to thank the EURACTIV Poland editor-in-chief Karolina Zbytniewska and the whole team to take up this subject and to invite so many renowned guests here today. The floor is yours. Thank you. Thank you very much, Mr. Jacek. Yes, this subject is very important. Every year, around 3,700,000 European citizens receive the diagnosis of cancer. Close to 2 million people in Europe dies of cancer. And the cancer is responsible for 20% of deaths at our continent, and over 40% of those deaths could be prevented. This is what we are told. Today's meeting is organized with the hope that when we have so many well-known experts active in creating new politics concerning cancer in the European Union, we will be able to have some influence, positive influence on this situation. Our panelists today are Professor Ted ALBREHT, called unofficial European Union head for combating cancer. It is European Joint Action Cancer for Combating Cancer from WHO, Bartosz ARŁUKOWICZ, former health minister, the head of the Special Committee on Beating Cancer in the European Parliament, Dr. JOSEP Figueras, from the European Observatory on Health Systems and Policies, Mr. John Ryan, the Director of DG SANTE, the EU Beating Cancer Task Force in the European Commission. We also have Dr. BETTINA, who is the representative of the Horizon Europe Cancer Mission Board and the former head of the working team for advising patients in a small European Society for Medical Oncology, and Professor IWONA ŁUGOWSKA, the head of the department for research in early cancer in Maria Sklodowska-Curie Institute Research. And last but not least, Anna Kupiecka, the founder and president of the Onkocafe Foundation. I would like to start our first round of questions from Ms. Anna Kupiecka. I would like to start from the beginning, from the diagnosis of the situation, the diagnosis in Poland. Miss Anna Kupiecka has had a breast cancer. Miss Anna, your foundation supports patients directly. Let's start with the diagnosis of the situation in Poland from the perspective of oncology patients. What is the Polish prevention, diagnosis, and curing cancer system? Where are we as a country? And where are our strongest challenges and problems? The question is broad and difficult, but I would like to give you 4 minutes to answer it. Thank you very much. I would like to welcome all of you here and thank you very much for this invitation to this meeting. I am very happy that the voice of patients and patient organizations is taken into consideration and is heard. In reference to the European Union data you have mentioned, I would like to say that in Poland we have around 160,000 diagnoses yearly and we have a growing tendency. Around 100,000 of those patients die, which shows that oncology treatment is 12% lower in its effectiveness compared to the European Union. We are the only European Union country where mortality due to breast cancer in recent years increased. And this is data from the National Public Health Institute, PZH. This is data from their last report. Therefore, we face many challenges concerning breast cancer and other leading diagnoses such as lung cancer. This problem is not solved. We also have other cancers which become problematic. We have Polish cancer plan. We have our national oncology strategy. Today, this is a good wishing document. It is a wishful thinking because we do not have funds directed to this strategy. Therefore, in practice, we haven't realized any assumptions of this document. It is only certain obligations expressed by Professor Rutkowski from the Oncology Institute. From October, we already know that the budget from the national strategy has not been well defined, but we have achieved certain data as a General Polish Oncology Federation. I am the president of. We have the data showing that the ministry has already dedicated more than 10 million Polish zlotys, more than 40 million Polish zlotys to the realization of the national program for combating cancer. Previously, it was a document operating in Poland based on which oncology healthcare was realized. The National Oncology Strategy has been decided on in February this year, and it is a document which was broadly discussed. Many groups referred to this document, sometimes in a criticizing manner. We noticed that this strategy repeats the mistakes indicated even if the analysis of the Supreme Audit Office, Polish NIK, and sometimes it is difficult to draw conclusions whether within the national oncology strategy will be able to not to repeat those mistakes. I hope that we are all aware of those problematic areas and all the experts in the healthcare domain are aware of our problems and our challenges, and they will do their best to make use of the conclusions and best practices and to improve them. The biggest problem from the point of view of patients is the organization of the oncology care, access to information and access to services. It is depending on the postal code in Poland. Therefore, patients from small villages find it difficult to understand what they should do. They also have quite simple problems concerning commuting to oncology center. More often, the oncology patient's path before the diagnosis is not a straight path. Patients in Poland, at least in my opinion, spend too much time going from one doctor to another without proper diagnosis. Therefore, this is a huge area for improvement, to improve quick diagnosis at an early stage of cancer so that we can implement adequate cancer treatment as early as possible. This is the most frequently noticed problem. And I think that it may also be the cause for high mortality due to cancer in Poland. I think that the European Cancer Plan can address this problem. Thank you very much. The situation doesn't seem to be optimistic right now, but we hope that we have potential for improvement and that we will benefit from it. Let's stay at the diagnosis of the situation in Poland, but we should look at it from the new pandemic situation. I have a question to the Member of the Parliament, BARTOSZ ARŁUKOWICZ. What is the situation of combating cancer in Poland look like from your perspective, and what is the impact of the coronavirus pandemics? Thank you very much. Can you hear me? Yes. I would like to welcome all the guests. Well, the subject is very broad, and we could spend many hours discussing it. We have several areas that concern us today, that will concern us tomorrow, and areas which we have to pay special attention to during the coronavirus pandemics. Today, in Poland and in Europe, the pandemics has multidimensional consequences, not only for those who are have certain contact with the virus, for those who are suffering from the virus. This is the one problem. And another important problem, in my opinion, maybe it is even a more important problem, this is the consequences of the pandemics for treating other diseases such as cancer. In Poland and in Europe, we notice much longer initial diagnosis, preliminary diagnosis time. Right now, we have patients with advanced cancer. We also have patients in terminal stage because they didn't have any access to medical health care. It results from several problems, and the veritable consequences of COVID will be observed in the coming months in the form of increasing cancer incidence of advanced disease. So such patients will have smaller chances of survival. Some data.
So in the Silesian Voivodeship, a great agglomeration in Poland, in April 2019, more than 1,000 mammographies were carried out, which is still too low, but it was 10,000 as part of prevention in 2019. And in the same month of April 2020, so during the pandemic, it was only 400. So we are talking about a difference between 10,000 and 400. And now let's take the Mazovian Voivodeship, so the region of Warsaw. The same month, it was 8,200 mammographies. And in this year, the same month, it was 380. It is a clear sign that we fail to diagnose cancer, that the delays are dramatic. The cancer did not stop because of COVID, and this is the main challenge we are facing nowadays, to ensure early diagnostic and ensure access to safe treatment. it is my opinion that we have made certain mistakes in managing the pandemic, because it is essential to create a network of the so-called white hospitals, which means hospitals that are to a considerable degree protected from virus in order to fight other diseases that need to be treated despite of the pandemic. A high percentage of medical personnel has been infected. So we have fewer and fewer medics that are active. The virus is present in almost every hospital in Poland right now. COVID units were established in all hospitals, including those hospitals who have very specialist units which are not available in other hospitals in Poland. So this is my opinion, but we also talk about it at the meetings of our special committee, and I hear that different member states have taken different approaches. Some are coping better, some worse. The treaty does confirm that member states are responsible for healthcare, but the pandemic has shown very clearly that perhaps certain adjustments will have to be made, because in terms of incidents or events that take a global scale, that affect the entire civilization, it is not enough. Cancer treatment is one of civilizational challenges that we are facing, and already during the first meetings of the special committee, it became very, very clear that the main problem in fighting cancer is connected to a disproportionate access to prevention and treatment. And it is my ambition that one of the possible outputs of our work would be to shorten the time until early diagnosis. So back in Poland, I tried to introduce some measures and made funding available without limits to all hospitals, provided that they provide early cancer diagnostics and start treatment early. There are also considerable disproportions in access to new technologies as well as knowledge. We have to create databases which will include reports about the application of new treatments, so that we have reliable data and so that we have an actual system of second opinion, so a network of reference centers, so that countries in which the oncology is not as developed as in others can learn from other member states. And it has to be a mechanism that will working truly and that will work smoothly. And I would like to apologize in advance because indeed I have to leave you at noon to attend another meeting, but I just wanted to add and underline the relevance and the significance of a database that would list all cases of atypical cancer progress, so that doctors, when faced with an atypical case, can inform other doctors about it or learn from the database to support other physicians in treating their patients. And finally, we need a common legal system in the European Union so that patients can be treated effectively and then continue with their lives and are not haunted by this disease until the end of their lives, because after completion of treatment, certain patients still have to suffer and lead more difficult lives than patients that never suffered from it. Thank you, and thank you for your numerous recommendations and proposals. Now I would like to turn to Professor IWONA ŁUGOWSKA from the National Institute and Oncology Center. We have talked a little bit about Europe's Beating Cancer plan, but Ms. KUPIECKA and Mr. ARŁUKOWICZ mentioned a few existing problems. Could you tell us whether the Polish cancer plan addresses these problems in any way? And if you could maybe also compare it a little bit to the European Cancer Plan. And immediately I will ask about a question that came from the audience. So the report of the Supreme Audit Office was mentioned, and the question is whether or not the criticism expressed by the Audit Office has been addressed in the National Cancer Plan in any way. Thank you for this question, and thank you for this excellent meeting. I would like to thank especially Ms. KUPIECKA for her excellent remarks. As regards the National Oncology Plan, it is a general document that sets out the development of oncology in Poland in the next few years. It has been broadly consulted, so it is now the most important documents governing oncology. In Poland, it is based on the communiques of the European Commission, of European documents of the Social Committee, Committee of Regions, European Parliament, and a number of other documents. The emergence of this document was fruit of many months of work of a specialist committee chaired by Professor Rutkowski. The committee discussed all the existing practices applied in Europe, trying to identify the best ones. We've also talked to our NCCN and NCI partners from the United States. I would also like to thank Ms. KUPIECKA for pointing out our present situation, underlining all the obstacles we are facing, also the neglect that has happened. The national strategy had a certain timeline that we are supposed to follow, and we are trying to do it as much as possible during the pandemic. But I also want to emphasize that we are working on an opening report, a document that will tell us where we are, and on that basis we will be able to monitor the progress during the implementation phase. Also, if there are difficulties in implementing certain solutions, we will be informed about it on an ongoing basis and be able to respond very quickly. So the document now, this report will provide an instrument that will make it possible to be efficient and effective in implementing the cancer plan. Of course, we have to work across disciplines and professions, and especially emphasize prevention, both primary and secondary. It is true that it's very unsettling to see how the incidence is growing. We have heard that year on year, the number of cancer cases has been growing, so we have to address it through prevention. In order to do that, we need better development of science and transfer of technology. Both these areas have been addressed in the National Cancer Plan. Another important component of the strategy is patient care understood as something very individual, to address an individual person. I also observe problems that have been mentioned already, that it takes a lot of time for a patient to find the right doctor. And I realize that especially during the pandemic, the path of the patient has become even more difficult. So access to a coordinator who will provide individual support to every person, starting from diagnosis, of course, preferably early diagnosis. This person will be supported by competent personnel that will be equipped with the right tools to work properly. So as clinicians, we are really counting on these improvements. We are counting for early diagnosis to improve treatment, and certain measures will be taken on the local level and on the central level. There will be funding for that, and also the strategy underlines the need to develop our potential also in terms of clinical trials, and to increase the number of patients participating in clinical trials, because in this way, only in this way, we'll be able to achieve better results. Thank you very much. And in terms of housekeeping. I have a request to everyone. Please, if possible, keep your answers short. And
former chair of the Patient Advocacy Working Group of the European Society of Medical Oncology. So let's now, after this Polish context, have a broader systemic look on Europe without being so country specific. What are the major problems? What are the major problems that you diagnose in the cancer beating systems of member states and of the European Union as a whole?
So thank you very much for that. I always have this slight lag, but the translation is fantastic. So thank you very much for that, so that I can actually follow. You said you wanted a broader perspective, but I think something from where I stand, in the end, where we have to affect change and where the benefit of anything we do is derived is in a concrete patient, in a very concrete place. So we can talk high structure, high policy, that's all nice and well, but the real outcome is produced in a patient in a local environment. And from what we have heard earlier on, reaching patients in the periphery, I think is something that concerns us all, and that should be one of our ambitions, that how to get high quality care to everyone, not just a few islands. My background is research, and I'm passionate about research, and I also like the high tech potential, because something that I cannot accept being medically trained and research trained is that we have these bright concepts sitting in a lab while we have patients dying, and we fail to translate this potential into something concrete. And that's something I will never be able to accept. At the same time, we had in our discussion before talked about what type of research patients actually need and want. And something that I think is very clear now is that under COVID, our incidence is rising. What we need is more effective earlier detection. And I think what we now need more than ever is research into our healthcare systems. It's not just with a pipette in a lab. It's also researching how our systems work in order to improve them. Because if there's something I've learned, so I've been now talking to many, many people across Europe in the last month, what I've realized is, first, it is highly complex. Healthcare systems are so complex that it is impossible to, if you do something here, to really understand all the ramifications of it, unless you have someone whose job it is to monitor these ramifications. And on top of that, we have pockets of expertise in different places, but it's a matching challenge to get, as you said, the right patient to the right place as fast as possible. So I believe what we need more now than ever is a way to study it, to learn it, and to improve it, and say, okay, this is working well. How can we copy this? How can we increase it? How can we make it systematic? And I believe that's something, well, that's my hope, that we as, you know, as a European Union can support each other in doing that, because there are great examples, and we can maybe talk later a little bit more about it, where some initiatives are already achieving this, getting cutting edge diagnostics out into the periphery and the learning back, and getting people into trials. So I believe that this is something that is more needed, and now needed more than ever before. And I think that's where the potential is. It's very easy to say it's not working, we have problems. Well, we all have problems. We also never have enough money. It won't get more. But I don't believe it's entirely true. I think we have expertise. We have fantastic people wherever you look. It's how do we put them together? And for that, it needs expertise as well. And I think from a patient perspective, you know, that's the fastest we can go. If we say we need more specialists, to train a medical specialist, it takes a generation. We don't have that time, and I'm not willing to wait and see people die and then. So it's more, how do we get smarter with what we have? And I think COVID has shown what we're able to, right? I mean, I think we've all been surprised how fast things went under COVID. And I'd like to see some of that translate into cancer for better outcomes for all of us. Thank you.
Thank you very much. So now I would like to ask Professor Tita ALBREHT from WHO Europe to briefly follow on beating cancer among different EU member states, and where the differences come from, and how to vary these differences. For example, by better construing national cancer plans, and by the better use of European programs. What's your view on that?
Hello, good morning. Thank you for the invitation. I think one of the main sources of differences across the European Union, of course, are the differences in approaching structuring care. And I will allow myself to comment that I looked at the targets, for example, of the Polish cancer strategy. And it's clear that it is for the first time touching upon the whole journey of patients. So it's touching upon occupational issues, upon prevention, care, research, which Bettina underlined, of course, research, and we need research. And this is something that I hope that will arise also from the Europe's Beating Cancer Plan, is the research on implementation challenges, on how services are delivered, and on top of everything, how what works and what doesn't work. Because the countries are often puzzled and they are trying to follow some examples from other environments, and this is not always reflected appropriately. I would think that many speakers before me from Poland spoke about the rising incidence and mortality. Of course, we have to see also the specific situation in the country. Mortality is not always a very good. Professor Coleman, is one of the leaders of the Concord study, would even challenge that fiercely. Mortality will drop once you can harness incidence much better. But of course, we have to face the fact that our societies are aging. Even Slovenia, the incidence, absolute incidence on cancer has doubled in 30 years. This is something that you cannot basically avoid, because this is all already in the process. So this is also impacting some of our performances. And of course, some countries that that some years ago seemed still to be doing well in terms of cancer are now catching up demographically and also following epidemiologically. My last reflection on your challenges is, of course, having good epidemiological evidence, but then, of course, setting clear priorities. I think that clear priorities and supporting them with adequate investment. And of course, realistic targets. I think that it's hard to promise too much in too short a period. We have to try to go for low-hanging fruits early, but we have to leave complex issues, complex challenges to a later stage. So even screening programs can give quick results in certain cases, for example, in colorectal cancer screening, in cervical cancer screening, but in others, there might be more challenging. One of the advantages of national cancer plans is definitely mapping the whole trajectory of cancer control and attaching all the necessary resources, where I would underline human resources, structural, that means facilities, and financial resources. This was also mentioned earlier at the beginning. And I think that without financial resources, of course, we can write very nice documents, but if they are not supported strongly by investment, then they will not yield good results. Thank you very much.
Thank you very much. Now I would like to ask Mr. John Ryan, Director of Public Health, Country Knowledge and Crisis Management for the European Commission's Director General for Health and Food Safety, DG SANTE. Two questions in one. I would like to ask you to shed any light on the emerging Europe's Beating Cancer Plan. How will it suit the diagnosis that we are listening to at the moment? Diagnosis of all the troubles that Europe and member states face as regards beating cancer, and how COVID-19 has influenced the works on the cancer plan of Europe, and what role does research and innovation play in the emerging European cancer plan? So it's actually 3 in 1.
So good morning, everybody, and thank you for the invitation to speak to you today. The Europe Against Cancer plan which we are developing at the moment, is one of the flagship initiatives of the European Commission, together with the Green Deal and the Farm to Fork and a couple of other big scale initiatives. So first point I'd make is that we want this initiative to be a major one and one with major impact. Second point I would make is that this is not being dealt with as a cancer plan limited to the health sector, but we want to try and mobilize the different levers which we have at European Union level through our different policies in order to impact or to increase the impact of the cancer plan. So the cancer plan, as we've developed it, has four main chapters, the first being prevention. And to give you an example of what I meant by health in all policies, or cancer in all policies, what we're trying to do is to leverage the agricultural policy to promote more healthy diets in the population, which will of course then have an impact on prevention of cancers over the years. So that's an example of where we're going outside the public sector and trying to mobilize the agricultural policy, which, as you know, is a big important project policy area. A second example in the area of prevention, where we're looking outside health, is in the area of taxation, because we know that taxation is a very strong public health measure, but it's not dealt with by the health ministries usually. So what we're trying to do is to mobilize the European legislation on excise duty in order to create a dynamic to tax products which are unhealthy in a higher way. Thinking here particularly of tobacco and alcohol, of course. So we're going to try and not just continue what we're doing already on prevention, but try and really step up and come up with some new ideas. Also looking at the young generation, because I think it's not just a question of trying to address the population as a whole, but also looking to try and create a new generation with a lower cancer risk. The second area of attention for the plan is the area of early diagnosis. And since 2008, we have had a European consensus on cancer screening. And on the basis of that, we have developed many guidelines and many implementation manuals, for example, on quality control, on the different cancer sites, which are covered by the recommendation. And we have seen a huge increase in the access to screening since that first European recommendation was adopted. But of course, time has moved on. We now know that there are other cancer sites which might be interesting for screening. And secondly, we've also seen the scientific world has moved on, and we have different techniques for carrying out screening. And thirdly, we really want to focus on the inequalities aspect, because there are huge differences in access to screening between the member states, and this is not simply not something we can accept for the years to come. The third area is in the area of diagnosis and treatment, and here I hope that the pharmaceutical strategy, which has been published by the Commission just a few days ago, will provide some input to increasing the quality and availability of treatments for cancer patients, linked, of course, to the research agenda and development of new treatments through research. And lastly, of course, the issue of quality of life of cancer patients and survivors. So one of the points I wanted to make before I go any further is that we're talking about a Europe-beating cancer plan, but of course, many of the things we're proposing here will improve health overall, because many other non-communicable diseases, such as cardiovascular disease, obesity, or diabetes, are also affected by the same type of determinant, health determinant. And therefore, we hope that the cancer plan itself will also have knock-on effects or parallel effects on other disease groups. The financial actions, the financial support for these actions will come through the Europe for Health program, which is being negotiated and finalized at the moment in the Council and the Parliament at European Union level, and also by the research program and by a number of other financial programs at the EU level. So that's a quick overview of the cancer plan. I hope I haven't taken too much time, but I'm very happy to come back and give you more details later on.
Thank you. There is already one question for you waiting also from our listeners and viewers, but it's for the second round. So now, last but not least, the seventh speaker in the first round, Mr. Josep Figueras, the director and co-founder of the European Observatory on Health Systems and Policies. So we've heard a lot about the graveness of the situation. Almost everyone is repeating that the problem of inequalities, for example, in access to diagnosis and treatment. Why still so many people have to suffer from cancer in Europe? Why things don't change? And actually they are getting worse, as we are hearing.
I wish I knew. Thank you very much for inviting me, and a real pleasure from the Observatory to be here. The Observatory is a partnership between 12 member states, European Commission and the WHO. And actually, it's a good question because a lot of our work is not only developing the research, synthesizing the research, but trying to knowledge broker that research and ensure that that research is integrated in the policy making, in the decision making process. Because this is the paradox. Bettina, and I like very much what Bettina was saying about the need for more research and so on, and particularly in the health systems. There's much we don't understand yet. There's much we can learn on this natural experiment, which is our old continent. But there's a lot we know. We know that 40% of cancers are preventable. We know about those risk factors from obviously smoking, alcohol, fats, physical activity, and so on and so forth. We know that many of these determinants of these risk factors actually are important to other non-communicable diseases. And we do know that certain prevention programs, screening programs, as John was saying very well, are actually effective and cost effective. And we know others are not, by the way. We should not ignore that not all the screening is effective or cost effective. There's a lot of waste on screening as well. But we know, for instance, colon cancer is cost effective. And we know there are huge differences. Say the Netherlands or Belgium have around 70% coverage. While if you look at the other extreme, like Croatia, Cyprus, or others, or even Spain, actually, although the data varies on the years, is around 20-30%. Why? Because we know that there's a clear correlation between the screening and the impact on the mortality from colon cancer. And you could say perhaps a bit less extent, but certainly for breast cancer as well. We've seen an increase with the screening on early diagnosis and therefore more chances for better results. So to me, the puzzle that I like actually, Bettina, part of the research should be as well on behavioral change, on the political economy as well. So why is it that the evidence is so straightforward, both on primary prevention and secondary prevention? So screening and primary prevention, John said it beautifully. I mean, all these determinants that we can work together by labeling, by taxing, by regulating it. We have all the tools at hand. Why is it that we're not doing that? Actually, later on, perhaps we should be talking. Sorry, I missed some of the debate. It took me some time to get into YouTube. Apologies. But we need to talk about what happened with COVID. And could we harness this same power, the same energy from COVID for cancer? Because there's far more certainty in cancer than there is on COVID. And we're getting more better results on COVID than we're getting on cancer. So what's going on there? Well, you want me to answer rather than raising the question further. But it's just to say that a lot of that work has to do with the same problems we have with other NCDs. How do we change behavior? How do we get this into the political domain beyond the usual suspects, beyond those who are already converted, like those around this table today, and we get those into the Ministry of Finance, we get those into the prime ministers, as we manage now with the COVID. So they realize with very relatively small investments, you can get huge results. And then there's this issue about freedom and choice and so on, which is being misunderstood. So it's part of the political economy, it's part of the context that we don't quite understand. Also, I think another element, we know an awful lot why TID was beautifully reflecting as well on the cancer plans, was reflecting on the integrated care, was reflecting on the implementation of prevention programs. So again, the evidence between countries is actually there. It's a matter of how we stop talking to each other and bring that to a different level of the policy process. We put more benchmarking. We should be talking about the differences, Carolina. I mean, the country health profiles we did under the leadership of the European Commission from John Ryan and colleagues, and together between the OECD and the Observatory, show differences, let's go back to colon cancer, of 20% survival in 5 years between Latvia and Belgium. Is what Belgium doing so much expensive or complex to do on that? 20% difference in mortality, in 5 years mortality. Similar numbers with prostate cancer or breast cancer. This is outrageous. And this is not just, as some parts of the industry want to prove, about access to treatment. Yes, some medicaments, some pharmaceuticals are important, but it's much more than that. Tit was saying it, the integration of care, the way that we go, the primary prevention, the secondary prevention, the way that we link the networks of treatment. So again, I'm sorry, I'm going round and round. Let me summarize. The evidence we need to make a difference is there. We've seen enormous improvements in parts of the eastern part of the region in the last 5-10 years. And we saw what they did, what they adopted and integrated. So I think the battle now is benchmarking, advocacy, political processes, and bringing this debate, like in the moonshot kind of debate we had in the US, and now with the Beating Cancer Plan in Europe, at a different level as we manage with COVID. Probably I haven't responded, but I tried to go a certain way in that direction. Thank you.
Maybe in the second round, you can give us more advice on the benchmarks and advocacy so that we start from you. But now off to Minister BARTOSZ ARŁUKOWICZ. Chciałabym zadać też pytania, bo się pojawiają od...
Mr. ARŁUKOWICZ, I have a question that we received from the audience, but I will maybe make it shorter because the question is very long. In any case, this is a question about your yesterday's meeting with the special committee in the European Parliament. So the first question is about a radical approach to alcohol. So what would you say, what approach should be taken? Should we increase the prices for alcohol and reduce its availability? This is number one. Number two is cigarettes. Yesterday, many speakers repeated the harm caused by smoking cigarettes and e-cigarettes. And do you agree that tobacco alternatives are being demonized in public debate? Should vaping be included in the cancer plan as an alternative method of helping people to quit smoking? Okay, there was one question about alcohol, one about cigarettes. What do you think about introducing the sugar tax? tax. What do you think about vaping and other products that heat tobacco up rather than burning them? And what are the main goals of your committee? What are the main challenges you are facing? And what should be the coordination on the European level, like so that we can combat cancer in all member states? There are so many questions. I'm not sure if I can answer them. I'm sure I cannot answer them in 3 minutes. I would maybe be able to answer them in 30. Yes, it is true that during yesterday's meeting of the committee, experts from all member states represented during the debate clearly indicated that the consumption of tobacco and alcohol is very harmful and exacerbates the cancer situation in Europe. Different proposals have been made, including limiting access to alcohol and raising prices. But I believe that raising awareness is the most important instrument, because all bans lead to illegal trade, to certain trade, certain gray zone where these products can be bought. So raising awareness is the way to go. We already have legislation in Europe. The point now is to apply it. Of course, certain restrictions are necessary. Whether I would support complete bans, I don't think they could be effective because they would simply lead to the emergence of a gray zone. And challenges, well, our committee has a number of priorities. One of them is to provide fast diagnosis and introducing standards for all member states that would not be binding, but that all member states could strive for. Also, better financial incentives for other incentives for the public and for member states to promote screening, financial incentives for those member states who will make efforts to increase the scale of screening. Also, preventing deficiencies in cancer medication. Several times in last years in Europe, we saw a crisis in availability of cancer medicines, especially critical ones. I remember that from the time when I was the Minister of Health in Poland. Such a situation must not repeat. As Europe, we want to ensure to our citizens access to COVID vaccines. The same should be done for cancer medication, so that we can never again see a situation in which access to critical medication is impossible in certain member states and we can do nothing about it. Yes, access is really necessary, and also exchange, so that physicians and doctors will working in small cities without access to large scientific centers can still have access to databases and knowledge and know how to treat their patients. It is unacceptable in the 21st century not to have more coordination in healthcare. We can build roads together. We have common infrastructure. We have common cultural policies, and we have nothing in terms of healthcare. I can't accept it, and I will try to convince my partners that we have to fight for more coordination in healthcare. We cannot do it separately, because of course every country is feeling right now as if we are sitting in a hot chair. But if Europe wants to be a community and wants to be strong, then we have to address even the most difficult areas, such as cancer care. We have proved that we can build roads together, that we can have a common financial policy, that we can have a Polish migration policy. It is time for a common cancer policy. If we fail to do it, the world will progress, and Europe will just stay and have to be ashamed for the quality of its cancer care. We can't accept it, and we have to do something about it. Thank you very much, Mr. ARŁUKOWICZ. I just wanted to say thank you, and I really apologize, but I do have to leave you. I wish you a fruitful debate, and I do hope that meetings such as this one will contribute to more exchange between different circles, the academia, practitioners, WHO, the European Commission, and politicians, so that we can make a common decision and agree that healthcare is not a matter of individual member states. It is our common concern. Thank you, Mr. ARŁUKOWICZ, and also ladies and gentlemen. I'd just like to say that after this meeting, we will write an in-depth article in Polish and English summarizing all the conclusions. Thank you, and stay healthy. Let's survive COVID, and then let's tackle cancer. Yes, thank you for that. I can only agree with what you've just said. Now over to Anna Kupiecka. Ms. Kupiecka, could you address the questions that have been asked by the audience? Let me remind you whether or not we should raise excise duty, whether or not we should introduce a ban on or certain restrictions on selling alcohol. What's your approach to e-cigarettes, vaping, and sugar task? Previously, there was also a question about the report of the Supreme Audit Office when it analyzed the previous cancer strategy, and whether or not the comments of the Supreme Audit Office have been implemented in the new strategy. And there is also one question from me. So referring to your first answer, you talked about certain problems and diseases that the Polish cancer care system is suffering from. Can you give us some recommendations? Well, I can only agree that it is really hard to answer all the questions in the limited time that I have, but I will try to continue on what Professor ŁUGOWSKA was saying, to keep it shorter. Well, we've been in dialogue with the Ministry of Health, and on the website of the Oncological Federation, you can see some information and records of the dialogue, and then you will also be able to find information about correlations, about the national strategy and our recommendations. And also, there were certain problems with the previous strategy, that the scope of reporting was not clear, for example. I don't want to go into detail right now. Please, if you are interested, please check the sources. The website of the Livia Foundation also has great information on this subject. As regards the excise duty, well, absolutely yes. The funds that are collected through the excise duty should be spent to a higher degree on healthcare. We repeated it many times, and yet it's not happening in Poland.
In Poland, we have the sugar tax, which we are proud of. We support it. The subject of e-cigarettes was mentioned here. It was also mentioned at the level of the European Commission. In Poland, we have great reduction in nicotine products, in tobacco products. We have noticed this. As somebody says here, it is difficult to have a ban on using tobacco products, but we can support people in going towards the healthy path. We can support them. This is something Europe can offer. Maybe the replacement products for tobacco dependency are the answer here. What can we improve in Poland? In my opinion, in spite of the COVID-19 situation, which is deteriorating the oncology sector quite quickly, we should do our best to implement the national oncology strategy. And as I have mentioned, we should update all the elements in the strategy so that in practice it can be more efficient. I am very happy that in Poland, the Polish Ministry of Health and other ministries and patients' organizations their voices are heard. Recently, we have been invited to the team working on recovery plan for oncology efficiency, especially the domain of prevention. This working team is operating, and as I have mentioned, I am very happy that patients' voice is heard. It is a standard in the whole Europe, but it is something new in Poland, and I am happy that our Ministry of Health is open to this voice, and we hope that we will be able to, as Mr. BARTOSZ ARŁUKOWICZ mentioned, we will be able to jointly develop approach to developing such prevention, which will be broadly taking into this work all the ministries and all the voices and all the stakeholders. In Poland, we face difficulties in collecting data, processing data, and benefiting from it. We do not have one space where we could aggregate it and where we could draw conclusions from it. Health policy should be evidence-based, based on good evidence, based on good analysis, which is the basis for good conclusions and recommendations. This is what we face in Poland, but I believe that we will be able to catch up with Europe in this respect. We have also differences in access to healthcare due to the economic and social situation of certain citizens. It has already been mentioned here. I agree with what has been said. We should work on inequalities among certain regions, and I think that the European Union can have a consultation and advocacy and advisory role here. We should have joint recommendation for certain cancer plans in member states so that we can analyze them and draw conclusion concerning what didn't work well. That would be the basis for further solutions. Thank you very much.
So you already answered the question on Zoom, but not all our viewers can see that. So that if you could briefly answer verbally. So we are quite the question: will Europe's Beating Cancer Plan cover also the issue of healthcare access for marginalized people, as for example, homeless people, prisoners, undocumented migrants who often experience serious health inequities across a wide range of health conditions, including cancer? I have another question from Roman Gutowski from Eurowybory, sent by email. Is there a threat then in case of the Polish, it's a political question, so you might choose not to answer. Is there a threat that in case of Polish and Hungarian veto, there is European Beating Cancer Plan will not be activated next year?
Thank you. So I think this question of inequalities I referred to at the beginning in my first intervention. And inequalities for me also includes the access to of vulnerable populations or marginalized populations to healthcare. And I include in healthcare the question of prevention, because of course, you know, if you don't include vulnerable groups who are actually at a higher risk of cancer in some cases, for example, through smoking or through unhealthy diets or whatever, it's not only a question of accessing to care, but it's also a question of the prevention aspect, which is something we think is important. By putting this focus on inequalities, we hope that we can at least identify where these issues arise at the national level. So it's not only, as JOSEP Figueras was saying, there are these huge differences in life expectancy and in survivorship, in access to screening. There are all sorts of differences between countries and regions, but also within countries and regions, there are these differences between different populations. And that's why one of the proposals we're going to make, and I'm lifting the corner of secrecy here on the plan, because it's not yet been published, but one of the initiatives that we hope to take is to have an inequalities register. It's not going to take 100 years to create. We hope to do this very quickly. And this will help us not to simply produce maps showing where the problems are, but rather to direct our financial assistance and our technical assistance to those areas where there's a problem. So instead of spreading the activities entirely over every part of Europe, it may not be necessary to do so. It may be necessary to have a more targeted approach, particularly where there are inequalities and groups of the population who may be particularly exposed. A second question concerned our approach to taxation, and particularly to sugar taxes and to the issue of
e-cigarettes.
E-cigarettes and novel tobacco products. Now, this is not a legal proposal as such, so we will not be including in the proposal specific changes in the taxation system, but we will be linking the cancer plan to the taxation question, because there is a link there in terms of the price. Also in terms of how unhealthy products are promoted, I think that's an important point. You know, we have European legislation on audiovisual media services, and this will also be part of the approach in order to see whether the existing legal arrangements for promotion of products to children and adolescents are sufficiently strong. So looking at the linkage with taxation, but also looking at promotion. And thirdly, as I said, looking at the promotion of healthy diets, particularly using the agricultural fund, the common agricultural policy. As regards novel tobacco products and e-cigarettes, these are already regulated by the 2014 Tobacco Products Directive. And these products are supposed to have a focus, the directive puts a focus on safety, on quality, on consumer protection, and on collection of information regarding these products. And there is, in fact, an opinion of the Scientific Committee of the European Commission, which is pending at the moment regarding some of these novel tobacco products. And finally, there was a question to me regarding nuclear medicine. There will be a part of the plan which will refer to the technical developments that have been made in nuclear medicine, and also the important need to have a strengthened training for health professionals in that area. So you know that there is a specific treaty in the European Union dealing with atomic energy, and part of that treaty covers nuclear medicine. So what we're doing for the first time is to make a link between the public health action and the Euratom Treaty in order to mobilize the activities and the resources of the Euratom Treaty. And by the way, this goes quite far, I would say, because we're also looking at the supply chain for medical radioisotopes. And those of you who are online and who are specialists in cancer will know that this is a big issue, because we have had a lot of problems with the security of supply of medical radioisotopes. And this is one of the issues that we'll be looking at as part of the Europe Beating Cancer Plan. So it's not entirely a paper plan, it's also a plan on the ground in a very concrete way. And I've given you some concrete examples of what we hope to do. Thank you.
So just to make sure, you consciously chose not to answer the veto question.
So you reminded me of the difficult question. Thank you. Yes, well, this does not apply only to the cancer plan. It applies to everything that we do, including my own salary, by the way. So if Hungary and Poland continue to oppose the adoption of the multi-annual financial framework, the result will be that there will be no budget at the end of the year, at the end of this year for the European Union. And what happens in these cases is that we operate on what we call a 12th. So we basically take the previous year's budget, we divide by 12, and we take that as being our provisional budget. So we don't stop work, we don't, but there would be a problem, I would say, in terms of implementing programs which would not be adopted. So if there's no research program, if there's no health program, because there's no budget, then all we can do is spend 1/12 of last year's budget. And since the health program, for example, would be going from 65 million euros per year to a much more substantial amount of money, you can see that this would have some effects. So we would just be in cruising speed, I would say, rather than being able to accelerate as we want to do.
Thank you very much. So now off to Bettina RYLL. This time, a very concrete question. How can we ensure that research mentioned by almost everyone, but especially by you and John Ryan in the first round, how research can deliver what really matters to the patients, because a lot of it doesn't?
I think, just like research is like, well, first, research is a very broad overview, as I said already at the first time. So there are different types of research. We have already mentioned systems research, but there's of course fundamental research. There's applied research. So it spans a really broad spectrum. So I think one part that I'm particularly interested from a patient advocacy perspective is how to turn findings into benefit as fast as possible. And people often talk about this as translational medicine. I actually think we have to think broader. We have to think about implementation. It's not just translating a finding into, let's say, a diagnostic tool. You have to also apply it in the research system and prove its value. And for that you need, and we have already heard that, I couldn't agree more with Anna, that we need data capture. We need to have our health records in a format that we can analyze them. We have to have a data quality that is as good as we can humanly possibly make it. And actually, if you look into precision medicine, we have to understand that this is nothing one hospital cannot do alone. This is even not something one country can do on itself. I must admit, I just Googled the population of Poland. So I am German by origin, 80 million people. I now live in Sweden, 10 million people. You are somewhere in the middle. But none of that is enough if we really want to tackle the really thorny issues. And if you think, for example, rare cancers affecting about 1/4 of all our cancer patients, this is nothing we can do by ourselves. So I think this is a typical one where European collaboration, we get our act together, can make all the difference where everyone benefits. So I think the trick or the challenge in this system is that on one side, we need this very high level agreement. We stick together, we set the standards, everyone plays by the rules so that everyone can benefit. At the same time, you have to be very concrete on the ground and get it into your hospital. So when we kind of shared the recommendations from the Cancer Mission for the first time, one of the criticisms, so I've been working on the personalized medicine recommendation. One of the criticisms I got was like, yeah, Bettina, that's a nice fancy construct for a fancy lab in a university hospital, but it never reaches the patient. And I thought, well, I'm going to prove you wrong. So I went actually actively looking whether there are places that are doing this, because I thought someone must have thought about it. I don't believe that this doesn't exist anywhere. And I've actually found a few. So for example, this is now Germany, not too far from you. So a little bit to the west is like the university hospital in Berlin, and it's surrounded by Brandenburg, which is a not very densely populated area in Germany. And they lost lots of young people after the reunification. It's in prostate cancer. elder men who don't like to travel to the capital, and totally stressed out oncologists because the density of medics in that area is very, very low, which is something you will be familiar with as well. So what they actually set up was a collaboration with the oncologists in the periphery, which is possible in Germany. I know that other countries have streamlined and centralized their cancer care. Germany hasn't, so that's another topic, not for today. But they have linked up the periphery with the center and have now streamlined their diagnostics. And the center provides help and support for the periphery, which is my ideal of care, close to the patient. It is not the patient who has to travel. You keep the personal contact that people value, because in the end, care is also about a personal connection. And you get the quality, or top quality, into the periphery. And they learn it, and they have established learning loops, and we don't have the time to go into detail. I'm happy to share the details, but I think it is about building learning systems, because they continuously improve what they're finding, which helps them to refine the care and have an entire loop going. They have the local payers on board who like it, that it streamlines care, it improves the quality, it reduces the variability in care. So it is something, one of these systems where everyone sees the benefit in it. And I'd like to see some kind of, we need some implementation knowledge. How do these loops work? Well, how can we, I call them learning loops, because you learn all the time, you get better, you improve as you go along, and you improve daily care. You don't have some fancy construct and then you hope for some diffusion that it will eventually potentially automatically get taken up. That's never working anyway. So I believe we have to start with everyday care, because that's motivated, it matters, and build on top. And I do think we can do it, because it's already going on. I found another example in radiotherapy. I found an example like what the hematological community has done, how they've refined, like, for example, BCR-ABL testing over the years in clinical trials. So there are examples of people thinking like that. And I think that's something, that's what I'm passionate about, cutting edge care, like by combining expertise that we can't have everywhere, but that reaches a real person living in a remote village wherever you want. I think that is what I care about. And I do believe that we owe our people that. I mean, we've heard this before, it's not acceptable. The variability in healthcare in Europe, this is unacceptable. We get a common currency sorted, we have roads, we have unified our education, but healthcare, I mean, really? So, but I'm not as negative as I was when I started, actually, because you find these examples, you talk to these people and they're happy to show everyone around. So it is possible. So it's more about how do we get started? How do we support each other to, that everyone can build their own loop on top of their system and continuously get better. So that would be my hope for it. And that is what makes a difference for people, for real people. Thank you.
Thank you very much. It is possible. Let's stick to that. Teraz mam pytanie do pani profesor Iwony Ługowskiej.
Now I have a question actually two questions in one, to Professor Ługowska. The National Institute of Oncology, among other things, tries to improve medicines that target certain types of cancer in a very accurate way. Is such research supported in Poland and in Europe, or is innovative research supported at all? How does it work? And unfortunately, Minister ARŁUKOWICZ had to leave us, but we have representatives of the European Parliament. Of course, I will send Mr. ARŁUKOWICZ the article, and I hope he will read it. We also have representatives of the WHO. And so if you could say, Professor Łukowska, what would Poland most need or expect from our European and international partners? Well, I would like to continue on a precise targeted oncology that was mentioned in the question. This is, among other things, one of the things we work on. Yes, precise oncology, targeting very specific mutations of the cancer cell. So individualization and personalization of treatment at this level of accuracy. Center of Excellence for Precision Oncology was opened this year in Berlin, but also in Warsaw. We have a unit where we can work on the molecular level in order to make treatment decisions for specific patients. Of course, then we ask whether or not such treatments would be available in our case. But the most important thing is to have enough options. And these options are provided by clinical trials. Thanks to EMA, we have access to different findings from clinical trials, commercial and non-commercial ones. So developments in precise oncology and making such treatments available to patients. This is one of our objectives that we try to achieve every day. And it is already happening. Many patients already have access to such treatment, and I can see no other way than pushing forward in this direction to increase the number of patients treated in this way. So that's what's happening in our organization right now and in general. And you ask about our expectations or even wishes. Yes, well, for me, it is essential to provide for more collaboration, both nationally between disciplines, but I cannot imagine how we can move forward without international exchange, sharing knowledge with others, sharing new findings, informing about where we are, working on data from real world evidence or findings of clinical trials, having databases with the right proper structure that makes it possible to find information and also watch its development in time, but all that needs money. Without that, it won't work. So I think all these has to work together.
You told me when we talked before this webinar that cancer is a no-brainer or should be a no-brainer. I am sure that might become good news to many one day. In that opinion, you highlighted the importance of prevention. Why has prevention been so complex to achieve? Why is it so difficult to invest in prevention?
Excuse me, that was to me, Karen, because I couldn't, there was some problem with the translation. Is that question for me?
Yes, it's a question to you, Joseph.
Yes.
I
heard you now, yes. Apologies. No, I was trying to raise that issue earlier, and perhaps I think it's a lot of what we learned from COVID we could apply to this question, Carolina, because we've been able to, as I said earlier, it's no-brainer, it's the same point earlier, because we do know what works. We do know what is cost effective. We know we do have the economics of prevention data. John Ryan was mentioning already some of the regulatory mechanisms we can use at European level, as well as at national level, sort of from the marketing to the labeling to the taxation to the regulating the products, and so on and so forth. So we do know that that works. So again, it's an issue, as I was saying earlier, of political will. It's an issue of bringing that to that kind of political agenda. And in that sense, I think the COVID has given us very important lessons, for instance, around the political will. We see, for instance, that the EU can play an enormous role with the proposals of van der Leyen, our president, about how we can bring together the member states on areas that are of common interest and common challenge. Bettina was talking about earlier about the numbers. And actually, Bettina, many cancers have become rare cancers in many ways. So it's not just rare cancers, but if we look at immunotherapy now, it's actually every cancer has various types of ways of approaching it. So the collaboration that we achieved from working together with COVID could be applied, for instance, has been said already, in the European reference networks. which actually have been very effective, exchanging best practice on treating COVID. The same could go for areas of research. Again, sorry, Bettina, I keep referring to you, but can you imagine a situation, and you are raising that, in which apart from the mission, cancer mission funding horizon, you could bring together the funds on cancer research across the region, across member states, to bring them together in the same way that has partially happened with COVID, only partially happened. Can you imagine a situation in which EMA or ERA, our new agency that President van der Leyen has put on the table, could be monitoring those clinical trials and exchanging highest speed data? The other day, also talking to the Lancet, to Richard Horton in a plenary session of the European, the Worldwide Public Health Conference, we're talking about the impact of highest speed publishing. Can you imagine the impact of that on cancer? So we have a number of areas where international governance aspects that, again, van der Leyen has put on the table. And actually, let me announce as well, the Monti Commission that the WHO set up as an independent commission by Mario Monti and former presidents and so on, where we're trying to talk about how we bring these kinds of health issues to the high political agenda. So the Monti Commission is looking at COVID, but is looking at how the lessons of COVID can be applied into other areas. So what I'm saying is this kind of political will that we see at the European level now, this ability to bring countries together with some stronger governance, international governance, could be applied to access, could be applied to prevention, could be applied to far more rigorous regulation. John Ryan has been teaching me in the past. I've seen the work he achieved with tobacco. Well, the work we achieved, the Commission achieved and WHO with tobacco could be very much achieved in many of the other risk factors because the legislation is there. So again, it's political will. So you, EUROACTIV, have to play a stronger role, not only you, but many other organizations like you, in getting these kinds of messages to that kind of political level, because we see how with COVID, we have managed to get that at that level. So that's part, I suppose, of the lessons from COVID that could be applied to a stronger prevention across European level, and using the European Beating Cancer Plan as a good platform for that.
Thank you very much, Josep. So now off to Professor Tiit Albrecht to follow up a little bit on this prevention, how to make it more cost effective, what should be prioritized on the European level, and maybe what can a coronavirus pandemic teach us now?
Yes, thank you. Thank you very much. I think that looking at the health promotion as the primary prevention, I think that this is a huge challenge. It has been reflected upon by several speakers, and I looked also to the Polish data on, for example, lung cancer, because it was mentioned. The burden of lung cancer in women in Poland seems to be extremely high, because the mortality for lung cancer is higher than for women than for breast cancer and for colorectal cancer, which means that tobacco control is something you cannot even negotiate. You have to do it. And we know what the approaches are. I personally am very reserved about substitute products because they just transfer one addiction to another. It's smokeless, okay, but it's still a nicotine addiction. So we are not solving the basic problem. We have to prevent youngsters to initiate smoking, because this is actually then the commitment into future generations. I think we need a comprehensive approach at the European level. We shouldn't forget alcohol. It's a very difficult topic in Europe to tackle, but it's linked to a dozen types of cancers, at least, as IARC has put forward, and we have to be consistent on this. And then we come to, of course, to screening programs. We see that after the directive and recommendations from 2003, not even these 3 screening programs have been implemented in all member states. And this is one of the problems, at least not to the full extent. In the meantime, of course, we had a lot of changes, a lot of improvements. We have HPV testing, we have genetic testing for women for breast cancer, and we have changes in colorectal cancer testing. Apart from that, there is research on new cancer screening programs. And I think that very soon there might be some advances there, especially in prostate, very likely, and probably also some selective approaches with lung cancer, notwithstanding the fight against tobacco. Let me repeat that. I'm a public health person, and I cannot see just rushing into screening without, lung cancer screening without strong tobacco control. Otherwise, you will just increase the turnover. The next thing is, and this links prevention with clinical care and with access. We have to focus also on early detection. So low threshold for access for patients who are symptomatic or who have certain risks, also based on the family history and other exposures, professional exposures after all as well. I think that early detection is as important as screening programs. Screening programs are important in the proven cancers with big effects at the population level, but early detection for cancers where we do not have a specific marker yet, where we need to do a push, a move into better outcomes, then early detection is one of the ways. Thank you very much.
Thank you very much. I guess we have reached an end for today. Dziękuję wszystkim Państwu. Już jesteśmy nawet odrobinę po czasie.
Thank you very much for this conference. We are even few minutes behind the time. The general conclusions are that Europe, in terms of combating cancer, should improve on every area: prevention, detection, diagnosis, and care and treatment. We should reduce inequalities in access to research and healthcare. As it was mentioned, we should combat inequalities depending on the place of residence of a given patient, whether it is a periphery of center. We need better joint action at the European Union level, and as usual, the more financial resources, the better for us. Our guests today were BARTOSZ, ARŁUKOWICZ, Anna Kupiecka, John Ryan, BETTINA, RYLL, Professor IWONA ŁUGOWSKA, Joseph Figueras, and ALBREHT. My name is Karolina Zbytniewska, and I would like to thank you all very much for your presence here, for your expertise. Our partner and co-organizer today was the European Parliament Information Office in Poland. Thank you very much for your time, and I wish you a very nice afternoon. Thank you very much, and to the next meeting.